I'm going to turn it to Michelle for some disclaimers, discussions around public feedback.
Yeah, and because of the connectivity issues, I don't have the slides to present, but the first is just about the fact that this meeting is being recorded. And so by staying on the meeting and sharing anything in this meeting, you consent to having what you say be part of public record and posted publicly. And also please refrain from sharing any confidential information for that same reason. And the second thing is that we changed slightly our approach to public feedback. And so we will be reserving 5 to 20 minutes at the end of each meeting for verbal public feedback. If you are a member of the public, not a committee member that wishes to say something, please use the chat to let us know that you would like to provide some feedback. And then we will unmute you and give you 3 minutes to share at the end of the meeting. All right. And now we'll go ahead and just move into attendance. And I'm just going to give a few beats per person to say they are here. And then we'll go ahead and move on to the next person. So Michael Langer is present. Amber Leaders.
Yeah, hi. Sorry, I'm not on video. Amber Leaders. I'm a senior policy advisor with Governor Inslee's office.
Excellent. Thank you, Amber. Senator Moncadingra.
Thank you. I represent the 45th Legislative District.
Thank you so much. Senator John Braun.
John Braun, the state senator for the 20th Legislative District in Southwest Washington.
Great, thank you so much. Representative Lauren Davis.
Good morning, here from the 32nd. Thank you.
Great, thank you. Representative Dan Griffey. All right, Caleb Bantagreen.
Good morning, Caleb Bantagreen. I'm with the Addictions, Drug, and Alcohol Institute at the UW.
Great, thank you. Victor de los Santos. All right, Kiara Fisher. Alexi Orr. Amber Daniel.
I'm here.
All right, great, thank you. Brandy Flood. Cheryl Racer. Chad Enright.
I am here. I am the Kitsap County Prosecutor, and I am representing the Washington Association of Prosecuting Attorneys.
Great, thank you so much. John Hayden.
Here from very slushy Port Angeles.
Great, thank you so much. Marshall Glass. And Tyler Gagnon.
I'm here. I'm representing the Recovery House.
Great, thank you so much. Hallie Burchinal.
I'm here. I'm representing outreach workers.
Excellent, thank you, Hallie. Teresa Adkisson.
Morning, I am representing substance use disorder treatment providers. I'm an SUDP and a certified peer counselor.
Thank you so much. Sarah Gillard. All right, Donnell Tanksley. Donnell. Malika Lamont.
Present, Malika Lamont, representing Lead Washington State Technical Assistance and Boca, Washington.
Great, thank you. Addie Adwell.
I'm here. I'm with SCIU 1199 Northwest and Harborview Medical Center.
Great, thank you, Addie. All right, and that is it for the committee members' attendance. So I will go ahead and pass it on to Michael now for more thorough introductions for members that were not able to introduce themselves at the first meeting.
Okay. Thank you, Michelle. And I know we have a few folks that aren't with us today. I'm assuming it has a lot to do with coming off the holidays, and some folks extended their time into this first week. So I hope they're getting well rested for sure. We do have some folks that were not able to make our first meeting, our brief meeting in early December. And we wanted you all to have an opportunity to do what others did, which is to not only introduce yourself, but also say a word about your motivation or interest in serving on the committee. And so we'll come back to you if you're on. And I know this person was on, but she was on briefly and was not able to participate in the introduction. So we'll start, Amber, with yourself. Amber Leaders with the Governor's Office. Do you want to say a couple words?
Hi, Michael, thanks. No, I hadn't really given a thought to that, so I don't really know. I'm just excited to be part of the committee and to see where the work goes. But no, I don't really have any additional comments for this morning.
Amber, I may say a word on your behalf, which is we rely on you so heavily in terms of our work during session and outside of session time. Amber really is a leader within the governor's office that we can go to as we have to make policy decisions or make implement new policy or new programs. And she's there at the steady to bring the agencies together when need be to coordinate on different issues as well. So thank you for your leadership, Amber, and really good to have part of this. Senator John Braun, thank you for joining us today. Did you want to have a comment or two about your interest in the committee? Or?
Sure, thank you, Michael. So my interest is in kind of twofold. One is in making sure we have the necessary services for folks who are struggling with substance abuse around our state, not just in concentrated areas, but also available in communities around the state, and also that we have some sort of ability to keep people in treatment. This is from my perspective, this is one of the hardest things. It's not just having the treatment available, it's having some ability to keep them in treatment long enough to be successful, and where we've fallen short, I think, both in Washington and around the country. So I'm interested in how we do that. I think there's some ideas on how you do it. I'm sure I'll learn something about this I don't know. So I look forward to that. Thank you.
All right. And thank you for agreeing to serve too. Thank you, Senator. Next up, we have Victor De Los Santos. And I believe in the introductions, Victor was not with us this morning. Victor, have you joined us by chance? Okay, if not, we will try to hear from Victor perhaps in February. Kira Fisher. Kira, are you here this morning? All right, Chad Enright.
I am here, and thank you, Michael, and I apologize that I wasn't at the first meeting. So I'm the Kitsap County Prosecutor, but I started off my career doing public defense, and I spent about 5 years as a public defender. And so I've been able to see how the criminal justice system has dealt with substance abuse. And while there have been the occasional successes, for the most part, the criminal justice system, I don't believe, has handled substance abuse very well. And so I have been one who for many years has been saying that really in a perfect world, it would be handled under a healthcare model. And so I look at this as an opportunity to maybe do what I've said we should be doing. So we'll see how it goes. And I appreciate you having me and everybody for being here.
Yes, thank you for being here as well. And we look forward to your comments and thoughts about how we can improve the system and look at it from a health perspective. So thanks for joining. Let's go to Teresa Atkinson. Teresa, you were on.
Oops, sorry about that. Are we just offering an introduction in a few words?
Yeah, just Teresa, what we did in December, and we're offering an opportunity today for folks who weren't able to make it, is just give us a few words about your interest in serving on the committee.
Oh, sure. Yeah, sorry, I was absent. I was actually in Arizona at my commencement for my degree. So I couldn't make it to this, but I really appreciate that I got the opportunity to be on this committee. For me, as a substance use disorder treatment provider, the idea that we're moving in a different direction away from the criminalization of substance use and towards, you know, a healthcare model like Chad Enright was talking about, I think is a really important shift, and it's going to be really difficult for our society. And I'm super excited that I get to be part of the process of kind of coming to terms with what that might look like in the initial stages, and just be part of the conversation. I just find it really intriguing and important work that we're going to be doing here.
Thank you, Teresa, and congratulations on completing your degree.
Thank
That's
you.
wonderful. And as you can see behind me, this is not my house, but it very well could have been this week with all the snow we got on the west side. So coming from Yakima, I think you shared a little bit over the holidays with us over here. So
We got
thanks for
about
your
a
work.
foot. Yeah, we got about a foot of snow last night, so it's intense. We're with you now.
Okay, sounds good. Be safe, be warm. Let's go to Addie Adwell. Addie, are you on this morning?
Yeah, hi, good morning. I'm Addie Adwell. I'm a member of SEIU 1199 Northwest and a nurse working in office-based opioid treatment at Harborview Medical Center. And I'm excited to serve on this committee because it seems like it's a historic time for this to change the way that we handle substance use disorder in the state of Washington. And I know that my other colleagues in SEIU 1199 Northwest are so excited about this opportunity and really want to see it done robustly and strongly.
Great. Thank you for joining us and for representing the union. We really appreciate you stepping forward in that. So look forward to what you have to say. And I believe we have gone through then folks that either were not able to be here in December and are here today. Have we missed anybody in the introductions thus far?
Representative Jamila Taylor, I'm an alternate.
Terrific. Representative, do you want to say a word?
Yes, Representative Jamila Taylor out of the 30th District, serving with Rep. Davis. My interest is really about how we transition from the current system that we have, which is ineffective, to the healthcare model. But as we are making that transition, making sure that we are bringing the public along with us. There's a lot of chatter in our communities that they simply just don't understand and aren't impacted in all the same ways that that most of us here understand, and we can't let the negative rhetoric deter the goals of this committee and obviously moving towards a different paradigm. It's hard work, and so I'm happy to be a part of this process.
Thank you for joining us. Do we have Representative Massenbrucker with us this morning? Okay. We do have three vacancies that remain. Two of them are youth representatives, and we did extend the application process, I believe, to the end of December, and we have some applications. So we will be reviewing them, and hopefully we'll have our youth join us in February. And then also local government. We do have at least one. I think we actually had a couple applications come in to represent local government and going forward. And so we'll review those as well. And hopefully that person will be able to join us in February also. So that was our attendance and introduction. So thank you all for being here today. Next up, I'm going to have Michelle talk a bit about some of our cultural expectations of the committee, or ground rules. I don't know how we best want to characterize them, but Michelle's going to go over those so we know how to participate and actively listen, but also when to chime in and such. So Michelle, do you want to go over the rules a bit?
Sure, yeah, and I'm having a hard time pulling those up as well, unfortunately, but I do think that we can still have a conversation about it, and copies of the ground rules were sent out to committee members, and so perhaps you can find a copy in your email. But one of the things I wanted to make sure we discussed was something that Caleb actually brought up in the chat as well, which is the types of language to be using and avoiding as part of the conversation in the committee. For example, avoiding the term drug abuse and using misuse perhaps instead, and getting feedback from committee members about the kinds of language that is helpful in these conversations, and then also if there's any types of procedures that we want to be implementing to make sure that everyone has a chance to speak and have a voice, that I wanted to open the floor to those kinds of comments and feedback as well. So committee members, feel free to unmute yourselves and go ahead and chime in with ideas for some ground rules and expectations for committee conversations.
Sorry, this is Teresa. I always like a good ground rule around assume positive intent.
Yeah, excellent.
Yeah, Teresa, I think that goes with language also. If we misspeak, if we use some terms that are been dated and we need to use new terms, I think gentle reminders, right? We're all trying to do the right thing here, and assuming good intent is a great ground rule, and we can remind each other gently without getting too, I don't know, too upset about it, I guess. So.
What about staying solutions focused?
Yeah, that's a great one, Amber. Can you elaborate a little bit on that?
We know that we are navigating a really broken system, and everybody knows that. And we could spend a lot of time talking about problems and stuff. I would just like to see solutions to those problems brought up when we're talking about those problems. I think it would be the most helpful way to approach things, and want to inspire creativity and just the direction of coming up with ideas to solve these problems.
When we're talking about assuming, sorry, I didn't mean to cut you off, Holly. When we say assuming positive intent, I would also like that to be applied to when issues of language are being brought up, because as we have said, language is important. And when we're using stigmatizing and antiquated language repeatedly, even in the midst of having a ground rule that and constant correction, that there is positive intent when people are bringing those concerns forward, because the way that that language impacts people that have lived in living experience, and that we're trying to, as Amber said, Amber Daniel said, be solutions focused. And if we can't move past using language that is harmful, it's going to be difficult to get to those solutions.
This is Hallie. A ground rule that feels important to me is to be fearless. And if we're going to change systems, I believe we have to be willing to state our ideas with the recognition that we're in a group of people that will be open to hearing them.
Great. We'll leave it just a few more moments for any other feedback, and we'll be compiling this feedback into a new draft of the ground rules to make sure everyone is on the same page with that, and then review at the next meeting. But yeah, any other thoughts about some expectations of their ground rules around language or even visual. But there was something else in the ground rules I forgot to mention, that if we can have cameras on as much as possible, that really helps to facilitate presence. And so if there's anything else around even just, how we want to interact, virtually in the meetings, then that is welcome feedback as well for the ground rules. Yeah, Malika.
This is just a suggestion that we have some really important positions that aren't filled, such as the youth position. And I didn't know that the position had been reopened until the end of December, and I'm not sure that a lot of other people did either. And so that there's really clear communication, and also that the group might consider leaving those positions open if we don't find someone to fill them, because they are very important to this process, that those positions stay open until filled, rather than, to everyone's point, this is about transforming our current system. And so that means we need to break away from some of the structural components that we've had traditionally that frankly have been designed to exclude people with lived and living experience. So I would like to suggest that.
Yeah, Malika, we did actually ask for the committee's help to identify young people in December, and we got that help. So we do have some applications in. If they work, if we were able to choose them, we will get them placed. If not, then they will stay open until filled.
Mm-hmm.
Michelle, it looks like we have hands up. I don't know if you can see those. Looks like Senator Dinger's up and Caleb's hands up.
Sure, Senator Dinger, do you want to go ahead and speak?
Thank you. I just wanted to follow up on that. I don't know whether the definition of youth for under 21 or was, I should have looked this up, I apologize, was in the bill, or whether anyone would consider making it up to 25. And the reason I ask is because I've tried to do a lot of outreach to our youth, and a lot of the high schoolers that are interested, they simply can't attend because of school. And so the age group that actually is able to is more of a college-aged youth. And so that was just something I was curious about.
Michelle, did we go to 21 or 25 already? I can't recall. I know the applicants that we've seen are college for the most part. So it's at least 21. I don't know if it goes to 25. But.
Right. It's not something that was specified in the bill, so we were using a 21 or younger, but it's because it wasn't specified, a specific age, we could maybe perhaps raise that age and go to 25, because that's a good point about the availability because of school being a factor. So that's something for us to consider. Caleb, go ahead.
Yeah, I don't know what the right rules are, but I want to be very thoughtful about making sure we are meaningfully including people with lived experience in this type of process. Some of people are basically professional committee members, and we know how to do this, and we've been doing it for far too long. But for people with lived experience to have a truly equal voice, I feel like we need to figure out processes that are active and proactive to ensure everybody has a meaningful opportunity to contribute and speak, and not have to bump elbows and learn how to raise hands on Zoom and all of those things. So I don't know what the right way to do that is, but I know it needs to happen. And if anybody has any suggestions for that, I personally would really welcome that. But I've seen it on some other committees as well, where you get people who are very tokenized, and it's actually counterproductive and offensive. And I know that's not what we want to do. And so I would just put that out there, that it'd be very important, and particularly for youth. I actually reached out to some youth organizations as well and offered that I would be happy to be in kind of a mentorship role. And maybe that's a thing to consider as well. If people want that, and I'm not trying to say people need that necessarily, but to at least offer it, to make that offer available to people. How do these committees work? What do you do during the meeting? What do you do before the meeting? What do you do after the meeting? All of those things that are really important that are not intuitive. So I just put that out there for conversation.
Thank you.
Piggyback on that we reconsider maybe when we have these meetings, because these meetings are designed, it seems like, to maybe meet the needs of people that are working within this structure, not to create the transformational change that this committee is supposed to be designed to do. So that would be something else that I would suggest that we think about as a ground rule, that if the structure that we have is not conducive to the inclusion of the people that will be impacted by these decisions, then maybe we should reconsider that.
Malika, just for clarification, are you suggesting that we consider being outside of normal office hours, or even consider a weekend meeting? What can you be more specific about that?
All of the above. I think that if we're going to meaningfully include people with lived and living experience, we need to talk to them and ask them what would work for them, or we need to follow best practice for taking those things into consideration. Some of the things that you mentioned, having them outside of, typical 9 to 5 hours. That was also a concern for me. I was like, how are youth that are experiencing substance use, if they're doing the things they're quote unquote supposed to do, then they're in school at 9 a.m. And it's very rare that somebody would be able to get an exclusion to be able to attend a meeting like this.
Michelle, we would be a little bit of a lull here with the transition. I do see in the chat about a sub-advisory committee, people with lived experience. As this committee was chartered and populated, individuals with lived experience were at the forefront of the committee membership. And so we did recruit for that, and we were successful. We had lots of applications. And so we have quite a few folks who with lived experience that are on the committee. If as we go along, we think we need more of that voice, we can certainly look to other options, but just know amongst us that we have pretty good representation of folks with lived experience. And I think that came from the leadership in creating the bill. They wanted that. So we're thankful for those of you who stepped up and are willing to participate. And I think I heard the word fearless earlier, about being fearless in our recommendations, being fearless in our participation and engagement. And we do ask that all folks participate. We will try to facilitate in a manner that allows for that in a maximum way. If we find that those voices are being in any way subdued or not brought forth, we will look to adjust along the way. So thank you. I think most all of us have that interest in making sure the voice is heard. So Michelle, do you want to go ahead and move on to the next area and introduce Brianna as well?
Yeah. So I would like to introduce Brianna Peterson, who is our plan and report writer. Together, we designed and distributed the survey that went out to all the committee members to help frame the discussion, the bulk of our main discussion today. Brianna, are you on? I believe you are.
I'm here. Hi.
Do you want to give a quick introduction? And did you have a chance to, is your connection working to pull up those slides?
It's barely there, but I'm gonna try.
Okay.
So bear with me, everybody. So I'm Brianna Peterson, and so I am the plan developer and report administrator for 5436 in the Blakeville. So I'm here helping out Michelle, and I'm helping out a lot of these members to help us get to where we need to be. And I will, so if I pause at any point, it's because I'm taking notes, because this is part of it. We're writing towards the plan, right? And so part of that, what I wanted to do is, I know that there's a lot of surveys and stuff out there, right? We survey our community, we survey providers. I wanted to survey the committee to gain their perspective. Wanted to see how you guys see the services we provide and how you guys see the things that are happening currently. And so let me see if I can, we didn't get too many responses, probably a little less than half of you guys responded. But I would like to, I'm gonna try, bear with me. I can do this. I'm going to share. Can everybody see my screen?
Yeah, I can see it.
Okay, so these were the survey questions we sent out. There were 6. And we asked for your opinion on these things. I mean, a lot of it kind of like, hey, why is HCA asking what services are out there? Shouldn't you know? Yeah, we do know. But we wanted to gain the perspective from the community, from you guys out there, is how do you guys see them? And so these are the 6 questions. I don't know if you guys want to take a minute to look at them over if you haven't seen them.
Can you go back to Q1 through 3?
Yeah, I can. Hey,
thank you.
Brianna, can you say a little bit more about the intent of these questions and how it also coordinates with, I know, some other work that's going on at the same time?
So really my intent for these questions was to help us gain a perspective of what the intersection is with people and the community and the services that we have. And so I know you guys do a lot of work out there, and so you guys have the perspective from your locations, and that's kind of what I wanted to see. And actually, a lot of these questions I kind of thought were, I kind of knew where these questions, what the answers to some of these questions were going to be, and I saw that, and that's I didn't want to see it, but I did. It's like I know that there's stuff happening out there, and we can assume that, you know, we have all these programs, all these good programs out there, and everybody's using them, but that's not the reality. And so a lot of the stuff that I saw helped feed into that. And I know that there's other programs out there. I know SOAR does a lot of this stuff, and I know that ADAI is doing some of these surveys as well with the community, and we're going to be working with them collectively, because we're going to be providing feedback back and forth to help us really gain an understanding of where the disconnect is happening, because there is one. And what I did is, after we reviewed some of the survey questions, these are some of the common points that we were seeing surrounding harm reduction, communication, and policy and politics. And so I wanted to spend some time, I'm trying to see a clock because I can't see on my computer, spend some time kind of discussing and getting your feedback on some of the responses or anything that you want to add more to. And the harm reduction piece was that syringe program. There was like, I put it as an example in the question, and a lot of people took it and ran with it, and I appreciate that, because I know it's a hard sell. I've seen it before, but the few responses that we got have said it is a hard sell, but it actually is really useful. And so what about it is useful? And what about it is the hard sell? Is it the communication? Is it training? What are the pieces that we're missing? Because that will help us develop the plan to get these services out there. So I don't know if the committee wants to help kind of answer those questions for the first one on harm reduction.
Brianna, this is Michael. I think just a little bit more context may be helpful. We may have brought this up in January or in December, but we will be looking at existing plans, existing efforts that are ongoing. So we'll be looking at the Road to Recovery plan. We'll be looking at the State Opiate Response Plan. There's a variety of efforts underway as we look at housing and employment and a variety of other things that are already taking off. So we'll be pulling that into this planning effort. As we go through each month, what Michelle and Brianna and others are doing is going to tease us with some questions so we can draw more out from you as committee members. We can read those plans and we can consolidate them together and write a plan. But we want to know from where your lens is what you're seeing. And so this is our first opportunity to ask some leading questions and then start a conversation with you all. So be assured we're not starting from scratch, but we do want to get your perspectives, and today we'll start with that. So hopefully that helps a little bit. Caleb, I think you had the question, and then I'll turn it back over to our staff to kind of walk us through this. So thank you.
So I guess my first question, actually, Teresa, you have your hand up.
Yeah, you were asking for feedback on these questions?
Yeah.
For me, what I've seen, not for me, so what I've seen in regard to harm reduction is there's still kind of what I would call an old school mentality around what recovery is. And that I think that there are still a lot of people who only think of recovery as abstinence. And when it comes to harm reduction, we're not just kind of battling the people who don't really know anything about substance use disorder, but we're also, going up against people who have a very fundamental view about substance use disorder and initiate that directly to abstinence. And so when you have 12-step programs that say things like, this is an abstinence-based program, or you have treatment programs that talk about like, you're only in recovery when you're abstinent, you're going to have a much harder time helping people navigate things like medication-assisted treatment or safe injection sites or needle exchanges. And I think it's what I have been trying to really sell for people as far as that hard sell around harm reduction is recognizing that there is so much more to recovery, and there are so many other paths to recovery that don't just involve stopping drugs. If we just needed to stop using drugs, detoxes would be where it's at and we wouldn't need treatment. But the fact is that there's so much more to recovery and life than stopping the use of drugs. And there's so many different paths to recovery that don't involve just not using. So, let alone the fact that this is the way to save lives. And the other way, abstinence only, is not saving enough lives. There are still way too many people dying. So for me, it's all about recognizing and helping other people recognize, like there's a whole gamut of what recovery looks like. And I think there's just a lot of ignorance around that, and a lot of maybe I don't want to use closed-mindedness is the word that's coming to mind, but I think it's just a kind of a traditional conservative sort of viewpoint, and closed-minded sounds negative, and I don't mean it to.
Thank you, Teresa. I appreciate it. Amber?
Yeah, I have some experience with a couple different like needle exchange programs in different areas. Kitsap County. I think that what functioned in Kitsap County the best was that they were mobile. Kitsap County was really a lot of rural stuff, and they would actually come out to your house, and you could actually place orders with them, and they would just deliver things and pick up the dirties, and so that was really, I thought, a cool function that they had. I think that rural communities are really underserved with these kind of services. For me, I think that, and also Narcan, having Narcan at those needle exchange places, Narcan saved my life 12 times. And it kept me sucking air, and so I would have a chance at recovery. I think that's the thing that if people understood that about harm reduction, that it's meant to meet those basic needs to keep people alive so they can get to recovery, and that they can, so that they can get on the pathway to, you know, a life, and just keep them alive. I think it's the hard sell, I think, is that you know, when people hear harm reduction, that's all they think about is needles. And I think education is probably one of the biggest things to, you know, get out there, like, hey, harm reduction is about so much more than just needles, even though that is a big deal. And, you know, clean needles save lives. But I think that the hard sell is just getting away from that image of harm reduction just being about needles.
Thank you, Amber. That was great information. Haley?
Hi, yes, this is actually something I'm really passionate about. What I've experienced at our work at, I call it CAT, Compassionate Addiction Treatment, but what I've experienced within our treatment community is the word enabling gets thrown at us a lot, that we're enabling people. And it's from a level of our team with lived experience, it's been really difficult to communicate. And then from a professional level, it's been really difficult to find the words to communicate what this really means, that we're keeping people alive. That seems to kind of hit people as cliche, and we've been struggling to find how to help our professional community in Spokane understand the importance of this work. And we have people that have went from, I'm not interested in treatment at all, I'm just here to get some warm clothes, to now living a life that they are so happy and proud to live, you know. And it all started with harm reduction. And I feel like this is the piece of the work within this committee that is of the utmost importance, because it does, like others have said here, it opens all these doors to recovery rather than a narrow door. And that narrow door causes so many people to die. So I don't have an answer to this question other than just reflecting on our struggles within our own community. I know that we have treatment providers that say we're not a true treatment facility, we're licensed with the state. And that response from them is simply due to our deep embracing of harm reduction. So I would love to figure out with everyone here how to better communicate about this.
No, that's perfect, Haley. And that brings me to my point about communication. I was even having a discussion with a group, and I was like, wow, this is really great information. Is like, why aren't we using it? Like, is it out there? Oh yeah. Well, why isn't anybody using it? It's like, how are we getting that information from point A to point B to help the people? So my question is, like, how do you guys receive this information regarding services? Is it like directly from us? Are you guys doing your own research? And then the people with lived experience is, where was your first contact when getting the information? Was it at hospitals, first responders, the internet, like internet searches? I know it's what my parents did with my brother, so.
To Caleb's point that he just mentioned in the chat, that harm reduction is about connection, and it's about engagement with people. And that is where the communication happens the most. And oftentimes it's happening with the people that are experiencing the life that is bringing them to the service. I think that oftentimes, because of the nature of harm reduction work, and that because there is, it's hard, and people are so focused on the people that they are trying to serve, that the public relations work is not always as able to be done, because we're so much focusing on the people that need the services. But harm reduction, the demonstration is in the impact and how it transforms people's attitudes once they start to see the impact, when it begins to change the person's life, you know, like, and so finding who are the champions that can communicate that to other people. I think that that's how you start to get to, you know, addressing that hard sell. With LEAD, it's law enforcement. Those are the people that we work with most closely that are that can talk about how harm reduction has their participation in LEAD, which is based in harm reduction, is able to, you know, transform what's occurring in their communities. But we also have to talk about the level of, you know, resource and scope and, you know, expansion. So those are other things to think about. I don't know if that really answers your question, but.
No, thank you. And just to reiterate some of the ground rules, if you guys can raise your hand when speaking, just so we can make sure that we're all taking turns. Thank you. Amber, you raised your hand again?
Up. Yeah, Malika did raise her hand. It was just a different color, so it was a little harder to see. I wanted to say that once again, like especially with like testing sites at needle exchange vans and stuff, like Pierce County Health Department does that. And fentanyl test kits. Like I didn't know about fentanyl until I was handed a fentanyl test kit at a needle exchange van. I didn't know that it was being put into methamphetamines as well. I didn't know it was a danger. I was learning that stuff through that outreach. Outreach is how I got a lot of good information that probably saved my life. As far as the information that I got for the survey that I turned in for this committee, I went to the outreach worker that works for the fire department in our community, and I took him out to lunch and I just said, you know, what are some of the things that are, you know, you see going on in like the homeless camps and stuff here in town, and you know, because he's kind of like got those boots on the ground, and I wanted to get some information from him. I just think that it's everybody's responsibility to network, you know, like to be a conduit. And so the first contact when gathering information in this town is usually outreach workers, and there's a really scarily a few of them because we are kind of rural, you know, and people have to go out further to do the outreach.
Addie?
Yeah, thank you. I think the role of outreach workers is so important in getting information out to people who are seeking services. And I've really noticed that in the absence of enough outreach workers, people's primary source of information is other people with lived or living experience who aren't being paid to do the work. They're just doing it on behalf of the community, helping each other through mutual aid. So in terms of like the communication list, like people currently living experience are a huge source of information for the community of people who are seeking services.
Does anybody have anything else to add about communication? Okay, so there was a response talking about politics or policy hurdles in providing some of these services. Does anybody want to speak on that, please? Senator Dinger?
Thank you. It seems like the appropriate place for us legislators to chime in. You know, I agree with basically everything that everyone has said, specifically about outreach and that connection with individuals and that relationship. That is key. However, that work is the work that is not normally covered by any kind of insurance or Medicaid. And so I know many of us who are on this call are the ones who've been advocating for making sure that those services are actually paid for by the state, or that this be an important component of any work that we do. And so the hurdle really is finding a payment mechanism for outreach work, because it is not something that can easily be captured. So, I always talk about the stories of whoever the outreach worker is who basically gets that sandwich and coffee and meets that individual and sits down and talks to them. How do you bill for it? How do you show that? So I think there has to be a change in the way we think of engagement, in the manner in which we think of treatment. And so I think any ideas or suggestions around that, in addition to education, will be deeply appreciated.
Caleb, did you want to talk about the information you just listed?
Just to Lauren's point, we have been doing a lot of work with a whole variety of service providers around the needs that they're seeing with their clients, as well as the staff's needs for training and services around behavioral health, substance use disorder, and harm reduction. And I was trained in specialty addiction treatment 27 years ago, and that's not where SUD care is provided very often anymore. It's provided in a lot of other settings. And so seeing how it can interweave all of those things in different settings is where people already are, is the only thing that logically makes sense. Doing more of the same is not the most logical thing at this point. I think we've figured that out, and that's the point of this committee. So I just wanted to point that out as a reference. We learned a lot from folks about their needs and interests. It's a quick read. I encourage people to take a look at it, but I think it's very important that we get away from the sort of, to overuse the term, these silos between all these different things. And I think, and even in meetings we've been having with SAMHSA in the last few weeks, we've often talked about harm reduction as sort of the end of the continuum, and even tertiary prevention using public health language. And I've used that language in the past, and really realizing that's foolish and counterproductive. It's interwoven in everything. And if anything raises that point, it's fentanyl. If you're waiting to do harm reduction until after you've offered treatment services to a 15-year-old who's using fentanyl, they may well be dead. So harm reduction has to be interwoven into everything, and it is completely compatible. And in fact, addiction treatment is a type of harm reduction. So it really is thinking about how do we meld those things. And so that document is just sort of documenting another type of service provider and care setting where folks are, where we need to be supportive, and including my group also in terms of the training and resources that we provide, and also our need to better partner with housing, which is obviously an integral part of what we're all facing.
What I'd love to add, as a family law practitioner who's worked with folks who have substance use challenges, the family law bar in particular is not well versed in this, and there's a lot of trauma that individuals who would really benefit from harm reduction but still want to be in contact with families. They're challenged in terms of being able to have access to their children, have access to resources that would help them stay on a great path as they are navigating, difficult things. I would say the family law bar, which is different than dependency. Okay, so family law bars, it's really self-driven by the parties, and it is very traumatizing. It brings up all of the old harms that the person has been going through. So how do we help the legal system understand harm reduction? Because a lot of those arguments that are made especially in family law are part of the political policy rhetoric that we see on a daily basis with the work that we're talking about with harm reduction. Like, it's abstinence only. Until you can prove that you have had no contact with substances, you shall not have access to your children, or it's under supervised visitation, which can be incredibly expensive. So all the barriers that we're trying to reduce, and then the costs that already are difficult for many people who are trying to keep their head above water. So again, forgive me if I don't have all the language. I just know what I see in court and how folks are doing their very best, but are set back by the legal framework. And then that legal framework is also amplified in community conversations.
Thank you, Dr. Malika?
So now I'm going to speak separate from the roles that are listed on my square, but as a person who has provided consultation to healthcare entities throughout our state, clinics around, what harm reduction is and within the context of a continuum of health. This is, to Caleb's point and to a few other people's point, it's very crucial if we're going to start getting, people to understand all the different places that a harm reduction approach is necessary, whether it's the person at your front desk, whether it's, the person, like who is it that a person is coming in contact with, and what role do they play in the progression of that person along the cycle of behavior change. And I can say that it is transformational, just even having introductory, conversations with healthcare entities that are providing primary care. I felt as a person who worked in the Medicaid transformation demonstration, that was something that was, it mobilized our whole entire region, but I've also done it as a private entity to provide that consultation and education for healthcare entities across the whole entire state, and as well with, when I worked for Thurston County, I did it with our family court in collaboration, because I ran the syringe exchange, so I felt like I could speak about harm reduction pretty, with some authority. Anyway, but it was I had prosecutors that I still run into in our community that were like, thank you for providing that education. It helped me understand that, we needed to work with that person in order to get them to a different place in order to be able to have their children. The system is still what it is, but we have people that work within these systems. And when they can start to understand that this is a continuum, it's not just one type of programming. So I think that is a crucial thing that we need to start doing. I've seen it work, I've done it. So if that could be part of the work of this group, making that a policy change, that would be awesome.
Thank you so much, Malika. John?
And the whole process, I think we're engaged in, has to be seen as this evolutionary thing, because there is still among old school recovery folks and among old school treatment people, the notion that, for instance, MAT is simply substituting one drug for another. And that's a bad thing. It's not true recovery. It doesn't help you. It just pushes the problem down the road. That attitude is changing. It's not an easy change with folks, but we have to look at this as kind of an evolutionary process, and continue to educate people about the worth and the value and almost the necessity of harm reduction as the approach. But those old attitudes are oftentimes really hard to change.
Thank you, John. Does anybody else have any other comments? Well, I want to thank you. I thank everyone who did complete the survey, and I appreciate all your feedback that you guys have been providing. It's going to be super impactful as these meetings progress of the discussions that we're going to be having. So thank you. Michelle, do you have anything else?
No, I think that's it for that part of the agenda. And next from now until about 10:35, perhaps longer, depending on how much public comment there is, we are going to open the discussion to talking about barriers to services. And I know one of the suggested ground rules is focusing on solutions. So but this conversation will be focused on barriers as a way to let us know where the areas for solutions, are to focus on in a different discussion. So with that, I'll just hand it over to Michael to facilitate that conversation on barriers.
Okay. Thank you, Michelle and Brianna, appreciate it. And for all of you that spoke up, I thank you for your courage and your comments. It's important to hear from you. For those of you that may have sent in your survey and felt like you're on record that way, we do keep those. And if you have comments afterwards, you can certainly send those in to Michelle and Brianna as well. The next area we do want to get into is barriers of service, and really think about, our continuum is prevention, intervention, outreach, treatment, and recovery. This is really focusing on that outreach, treatment, and recovery. But if you yourself or you have had loved ones or neighbors or others in your lives that have tried to access services, whether those be harm reduction services or treatment services or recovery services, including housing and employment and education and things of that nature, we really do want you to take a moment and speak up to those barriers and to the ground rules. If you have an idea of a solution, like I've tried to get my mother into, outpatient treatment or residential treatment or housing support for 6 months, and I just can't figure out who to talk to. I think it'd be better if we had a single point of contact. Whatever that scenario is, think about what the problem is, and as you try to navigate, what you would have liked to have seen that might have made that easier. So we'll go ahead and go to the hands again. But again, if you've been involved in the our substance use system or had loved ones and had challenges with it, we really want to hear about that right now. So please take a moment, raise your hand. We haven't heard from you yet. Be bold, be courageous, raise your hand, and let us know what struggles you've had and what you would have liked to see in place. So I will stop talking and start listening a little bit more. So hands up, please, if you have something to say. Okay. And it looks like Amber, I see your hand up. If you have a comment about a challenge and possible solution.
Yeah, I work in peer support in Walla Walla, Washington. And that's how I'm here, is as a representative for peer support. One of the biggest challenges that I feel like we have here in Walla Walla is that there's no medical detox. You have to go to either Yakima or Spokane, or you have to go to Pendleton, which is in Oregon, and they don't accept Apple Health there in Oregon. So it's a huge barrier for people here in the Walla Walla area that there's no medically assisted detox here. Also, the idea that people have to go so far for a methadone clinic, they have to go to Pendleton for the methadone clinic as well. So people are having to, drive, what is it, like, it's like an hour drive or something. It's a long time. Anyways, yeah, access to withdrawal management is a huge issue. Yeah, for sure. What I was talking to Cody Main about, the outreach worker for the fire department, was that people don't have access to be able to transportation to come into town to be on medically assisted treatment. And he was saying that, a solution that he thought would work was what they're doing in other cities, where they're actually having outreach workers go to people and meet them where they're at and give them, long acting medications like Sublocade and stuff like that, injectables, And he said that was a solution that he thought could maybe overcome one of those barriers. I thought it was a really good idea. I know that figuring out who's going to pay for this stuff, like, is it going to be private donations, is something that we run into a lot, because we don't charge for any of our peer support services here. everything we do is completely free of charge, and we're mostly funded by grants and donations. It's very, we don't receive any, you know, offset from the healthcare authority or anything at this time. And it's kind of hard to come up with that funding. It's kind of like crunch time every time there's, you know, a new program we want to do or to keep a program going. So those are some obstacles that I've encountered.
Thank you for sharing, Amber. Really appreciate it, and appreciate you kind of bringing forth what others have suggested as well. So Teresa, it looks like your hand's up next.
Yeah, I just wanted to tack on with what Amber was saying, because as a SUD provider, we're definitely seeing a lot of access to withdrawal management is a huge issue in this state, and more of them are closing as opposed to getting things open. And I think that has to do with how we're reimbursed for services in that level of care. The requirement under the WAC when it comes to opiate treatment programs and withdrawal management is there's a huge disconnect between the kind of staff that you have to medically manage withdrawal, like doctors and registered nurses, psych ARNPs, things like that, and then what we're actually able to bill for and get paid for. And for example, when it comes to Sublocade that Amber was talking about, it's something that we have medical assistants in our facility that could, and a medical director who works off-site, we could offer this, but staff have to provide the injection. And in order for us to be approved to provide that injection, we have to have at minimum a registered nurse on site to be able to perform that service. So like there's this disconnect between what's available in regards to harm reduction, how effective that could be, and what we're actually as a treatment provider able to supply for our patients, because we do not get paid enough to have a registered nurse on staff. That's a huge cost. We have a contracted psych ARNP who works off-site and does telehealth for us. And then we have a medical director who has his own clinic who works off-site and does, you know, a lot of other services for us. But we can't, I mean, and this is probably bigger than this committee is even able to look at, but there's got to be some sort of like bridge between what's available and what we're able to bill for and get paid for, and what the WAC requires. I feel like the medications, the harm reduction models, all these things are kind of moving so fast that they're getting away from where the state is in regards to like policy and WACs and things like that.
Hey, Teresa, thank you for sharing. I think the solution you're offering is in part rates, addressing rates that will support the level of staffing required or adjust the staffing requirements. So thank you for bringing that forward. In the area of withdrawal management, I'll hold off. There's a whole category around workforce that we're all challenged with, I think, at this point, know about. So other comments, other barriers to accessing services and possible solutions that you'd like to bring forward. Think about, you know, the first time you tried to get into services, or you've tried to get somebody into services. How challenging might that have been? Or perhaps things have improved enough to where it is easier now, which we would love to hear. But other challenges to either recovery or treatment access.
Haley's on the phone and would like to make a comment.
Okay, so I'm sorry we talked over each other. Haley, do you want to go since you're calling in, and then we'll go to Malika after Haley. We're not hearing Haley.
It's possible she's not on anymore. It was about 7 minutes ago. She told me she was trying to raise her hand but couldn't on the phone. So we can maybe go to Malika now.
Okay, let's go to Malika and then come back then. Yep.
So one of pregnant and parenting people, that's an area that can be a real challenge, especially, I mean, even in areas that are considered resource rich, quote unquote. I hope everybody sees my quote fingers. Anyway, like Seattle. And then also that, you know, in Thurston County, where I'm also the co-founder of the Olympia Bupe Clinic down here. When we have pregnant and we're a low barrier buprenorphine provider, when we have pregnant and parenting people, it can be really difficult. They feel comfortable engaging with us, but then there's a lot of fear around engaging in the broader system in order to get their needs met, the care that they need. I would just doula services, expanding funding for doula services. Those have been proven to be very helpful in improving outcomes for both children, or for the child as well as the mother. For people that have substance use disorder, I think that that's something that could be a really great expansion. And funding,
Thank you, Malika.
also culturally relevant for people that, because we have a diverse community here.
I'm just gonna ask, I think Tyler, if you can hear us, working in the Oxford homes, I believe is your area you're coming from, where you hear from a lot of people every day, right? They're coming into the homes that many have come through and had access to service, maybe not all. But is there anything that you hear, Tyler, that you'd like to share in terms of what struggles folks have had accessing the system, or even accessing the stable housing services in the recovery?
Being involved in Oxford, which I've been for over 2 years, there's a lot of issues that people run into, not just with getting the medications that they need and stuff like that, but being able to get to certain places to get them, like methadone clinics, Subox appointments, things like that. But also a huge hurdle is coming out of treatments. I went to a long-term residential treatment center. I was there for 9 months. It was Cedronar at the time. Now it's Key Recovery. And in doing that, that was my 9th treatment center that I had been to personally. And that one didn't allow me to complete there until I had a job and a clean and sober place to live. Like, that was one of the requirements in order to complete that program. So being able to have that and get into a clean and sober housing and do that set me up better in the long term, because I had done the MAT thing before, and trying to be able to get to my appointments and find the locations to be able to do that. It was very difficult where I was at that time, which was back in Port Angeles. Being out here in Seattle now, there are a lot more resources for things like the MAT program and methadone clinics and stuff like that out here. But it is obviously a huge hurdle to have people get to their appointments and stuff like that. Not just that, like living in Oxford, like there's a strict thing about if you're on Suboxone here, we do pill counts and stuff like that, random UAs and things like that. But I mean, when it comes to like the treatment center aspect of it, and Oxford houses too, I want to push for more houses that allow children in them. In my Oxford chapter, there's 9 houses, and we only have 1 women and children's house in there right now. We have 2 women and children's houses in there right now, but there isn't very many in our area that even have men and children's houses. I want to see more things for parents trying to reconnect with their kids, and treatment centers that allow parents to have their children there, because you can get somebody clean, but them getting that relationship back with their kid, it's not something that just happens overnight. You got to put in that work, and they got to deal with the process of everything too.
Hey, Tyler, thanks for sharing. That's a really important perspective. I appreciate you getting on. I also want to ask Donnell Tanksley. Donnell, I think you are calling in, which makes raising your hand difficult. And so if you happen to be on the phone and have a perspective of folks in your area accessing services or challenges with accessing services and had any solutions to offer, maybe give you a moment as well. It's okay to take a pass. I know we aren't giving you a very good chance to raise your hand if you're calling in. So Donnell?
Yeah, well, thanks. So in terms of the accessibility right now, I'm talking with different teams here in Whatcom County to determine that. So I think I'll take a pass into the next meeting, and then I should have more information.
Okay, thank you. And thanks for reaching out and getting feedback from your community. I appreciate that. Haley.
you.
Hi, everyone. One of the, I don't know, I feel like Spokane might be similar as all other areas across the state, but I know that from both personal experience and from professional experience, when someone steps forward and says, I want to do this thing, I want to engage in treatment services, the barriers start popping up instantly, whether that's the ability to get an assessment, the ability to, from that assessment, navigate quickly into the care that the person is ready to engage in. It's like there's this window of opportunity, and then there's the way our system flows. And I've watched too often that window of opportunity happen where a person's ready, and then the barriers come up, and then that window of opportunity closes for a while when they're not ready any longer. And I've experienced people dying between those windows. And I feel like finding a way to make certain that we have accessible services at the time that window is open is probably one of the most important things that we can do. And I know I have a son in recovery. I'm really grateful he's in recovery. He's a little over a year in recovery, but there were several windows of opportunity that happened over that 10-year period of homelessness and struggle with substance use. And he was screened out of outpatient. Obviously, he can't receive services where I work. So he was screened out of outpatient because he wasn't ready to stop the use of marijuana, even though he was stopping the use of meth and heroin. And he ended up back in homelessness for about another, and struggling with substance use for about another 3 years after that occurred. And from a parent perspective, and being a parent that knows all the resources, I could not get my son the help that he needed when he needed it. And that's what I wanted to share. It's just that I think our treatment agencies are overwhelmed. And at times they may not fully understand how important that window of opportunity is. And so there's a lack of urgency. I just feel like that's something we need to address. That's all I had.
That's a really important comment, Haley. Many of us have lived your path or living your path and know how important those windows are. So thank you for sharing that. I think some of it may be policy, but a lot of it is capacity issues too, right? How do we get closer to treatment on demand, services on demand, outreach workers on demand, right? So when people are willing or ready to talk, there's somebody there for them to talk to. So thank you for sharing that perspective. Amber, let's go to you next.
Sorry, I wanted to just kind of touch on, Tyler kind of touched on this, but non-custodial parents that are trying to get into recovery, you know, there's a lot of resources for people who have the kids living with them. But, you know, non-custodial parents are parents just as much as custodial parents are, or, you know, they should be counted as. I actually had experience with this, you know, because I was one of those people that didn't get their kids back. And when I wanted to go to treatment, it was very difficult for me to get medical insurance. It was very difficult for me to get into recovery. And it was daunting. Like, I lost a lot of hope. I didn't have those resources for transitional housing where I could have visits with my children, you know, and take advantage of the visitation that I had. I didn't have any sort of legal advocacy to help me navigate my parenting plan and my child support. I didn't have, and those are all barriers. those are all huge barriers to recovery, you know, not just things like treatment, medically assisted treatment and stuff like that, but healthcare and housing and, you know, trying to like reconnect families. I noticed that there's no, I actually got to experience a pilot program for non-custodial parents through Goodwill Industries. It was where they were giving like job training to non-custodial parents to help them make their child support payments. And I'd like to see more stuff like that. I actually was able to get like my welding certification through that. It was really cool. And it really helped me to get to where I am now, even though I'm not welding anymore, you know, but it helped me to get into compliance.
Thank you, Amber. Again, really good points to bring forward. I'm reminded also for some of you, if you're not accustomed to these type of meetings, you say, that's great, raise your hand, but I don't know how to raise my hand. If you go on the bottom of your screen and there's a reactions button, it's got a little happy face, I guess, on it. You click on that and then there's a button there you hit that says raise hand. So I should have mentioned that earlier if folks have been kind of struggling with that. Addie, do you have a comment?
Yeah, thanks. I just wanted to add to what Haley was saying about how difficult it is just to get in the door for some folks where the appointment is scheduled quite a bit out from when they initially state they want it. And then that appointment is missed. And then it's unlikely that these overworked agencies have somebody who's circling back to that person to say, hey, we noticed you missed your appointment and we'd love to see you. Can we help you reconnect? So it's both an appointment time that's going unused and a missed opportunity for an individual. And just reiterating that, like, outreach to people in this pre-engagement time to help people stay connected and to even remember when that appointment is so crucial. And also to help them know, like, hey, you missed the appointment, we'd still love to see you here at some point soon, is so crucial in this service delivery.
That's great, Addie. And I think, you know, the use of technology and apps and, you know, text messaging and all of that, perhaps we can do better at following up with folks, both if they miss their appointment, but also sort of post-formal treatment, right? Checkups and check-ins and things of that nature have been brought up. And I think more folks are doing that, but really appreciate the point. Other comments? We have, are we out of time? Let me see here real quick. I think we have a few more minutes. If there are other comments about challenges related to treatment access. Now, these may be things you've experienced or things you've heard. And sometimes what we hear, there have been other things that come along to kind of help rectify that, but that's okay. I think anything that you've heard that are challenges to accessing services, we'd want to hear about now. So comments? Okay. If not, I would really sincerely like to thank all of you that spoke up. I know this isn't easy. The format's not easy. The disclosure isn't always easy. But, you know, being on the committee, this is really a good chance to kind of share these things you may have been holding on to or trying to get somebody to listen to. And this can help lead to solutions and lead to a plan that will make accessing services easier for Washingtonians going forward. So thank you. Your voices matter. And before we move on, I think, Haley, you have your hand up one more time. So do you have another comment?
I do. And I think this is one I need to navigate carefully how I word it, because I don't want to step on toes really. But one of the things that I experienced when prior to the work I'm doing now, when I was working out on the streets in the hub and spoke, was, and I apologize, I'm doing childcare for a medical thing today, was that when I would try to navigate people into care, it was a somewhat frequent occurrence where the attitude that the person I was navigated was met with at an agency actually deterred them from accessing care. The judgment that they were met with. And I actually found that to be more challenging in some ways than the lack of available services, because when that's encountered, the likelihood of a person attempting that again due to all the internal shame and guilt and all those things that are already present get amplified. And to watch a person want something and then to watch them fall away from it because they feel judged was really hard to see. I know at CAT right now, we actually, for our front desk person, we have a certified peer counselor doing our front desk because we're trying to make sure that someone that doesn't understand addiction isn't engaging and giving the wrong message. So I think that's a huge piece of access to care.
Thank you, Haley. Absolutely. The front office staff, the folks taking the phone calls, how critical is it, their customer relations and so forth. So thank you for bringing that up. Let's see, one more time. Any other comments this morning? Okay. Again, thank you for your courage, folks. Next up, we're going to go into public comment, and we're going to ask for some grace as and good intentions, expectation around good intentions. This will be our first time of doing it this way and doing it virtually this way. So legislators, you are much more accustomed to this than I think we are at the agency level. So we will take some time. We will have about a 3-minute window for folks to give their public comment. We won't promise reactions to questions that come in, but we will take them. We will see how far we can get in terms of what interest we have from the public that have joined us here today that may not be on the committee formally, but certainly have interest in the topic. So Michelle, if you are on, I'm not sure if we have an order at this point of who might want to comment first. If you want to comment, please put your name in the chat and we'll call on you. I believe we had somebody earlier that said they wanted to speak. Thea?
Someone that had
Thea?
Oh, Lisa, yeah, sorry, go ahead.
Okay, so let's go to Lisa first. And I think Thea had her name in earlier too. I'd want to get her in near the top if we could. But Lisa Dugard, did you have a comment?
Hi, everybody. Hello. I had to step outside to get away from my dogs. I saw Thea in the chat say that she was stepping away and would be back, by the way. I just wanted to thank everybody for everything that you've shared so far. I am privileged and excited to work on the development and launch of the Recovery Navigator program, working with Malika and many other people who many of you know, trying to make it real that there is a community-based care alternative to the criminal legal system for people who engage in formally illegal activity related to behavioral health issues and especially substance use. So, so much of what's been said is incredibly encouraging and promising. I'm really eager to see where you all take this over the next many months, and we'll be right alongside you listening. I did want to comment on the questions that arose around harm reduction and how to get past skepticism and political trepidation about harm reduction. From our work nationally, internationally, and locally with LEAD, I can just say it's completely possible, shockingly possible, because what is popular always is teams of people who come and solve actual problems in front of others. And take what appeared to be an unsolvable situation and showed progress. And that's what harm reduction does. Having a layer to the work that's intentional around communication back, kind of like retail service, like this situation existed, this is what we did about it, these are the barriers that we have, and this is the progress that we've made. It is astonishing the business, neighborhood, public safety groups, police, law enforcement, and elected official response. How dramatically that swings into enthusiastic support, as long as these methodologies are used to solve their actual problems. And of course, they're essential because most actual problems involve people who are falling out of other frameworks for engagement. And so we have to come, and when we do, we have never seen any permanent opposition to this. So we're with you. We can definitely help to provide like a shell of communication and messaging strategy around this work, but you will succeed in popularizing this methodology if you commit to it. And there's just so much empirical evidence that does happen. So thank you all. Here to support as needed.
Thank you, Lisa. Appreciate the comments. And I think we have Brad Feingood out of King County. Brad, did you have a comment for us this morning?
Yeah, good morning. Thank you for taking my public comment. Hello, everybody. Good morning. Brad Feingood. I work for public health in Seattle, King County. A number of things, and I apologize. Taking notes in the chat for Zoom is now something that I will try not to do, because if you mistakenly hit enter, they become notes for everybody. So please, but there's nothing in there that I won't be talking to. So, I just wanted to say thank you to everybody. The conversation today has really been actually really enriching, and really it's brought out a number of great viewpoints that people have experienced as far as barriers to care. I think it's important, this framework of just operationalizing solutions and not talking about barriers, I would push back on a little bit, because there are so many barriers to care. And if we can start to identify what those barriers to care are, then we can collectively come up with solutions. It sounds like more and more and more increasingly, whether it's from a workforce issue or from policy issues or from managed care related issues, are having trouble accessing our system of care, or whether that's our system of care is not the right system of care, especially at the front end and maybe on the back end. I heard that time and time again today. I wanted to lean into what Haley was saying about how we have a system of care that is so regimented, and somebody who can't get care because they choose to smoke marijuana, but they're stopping on using heroin and methamphetamine. And in my world, that is heartbreaking, because those are the people that we're going to count as numbers that have died of overdose or have experienced overdose or that can't access systems of care. So we need to reimagine, not only just within workforce issues, but we need to reimagine what care looks like. Another thing is that there's nowhere for folks to go. If our front end for our treatment system is detox, what happens to the people who don't want to detox, right? Where do people go? There's no pre-detox in our system. There's no open engagement with our system. And, thinking back on what Caleb said about how when he went to school, or he goes to school still every day, but when he went to school 20 years ago or 25 years ago, that, there was a school of thought about what our system of care needed to look like. And it's very, very different today. I would also implore this group to lean into the voice of people that are actively using drugs, and whether that is reaching out to groups of people. We have a program in King County called the the Council for Expert Advisors on Drug Use, people who are actively using drugs to help inform policy, because those are the people who know what's going on. And the other thing I just did not hear too much of today that I would implore you to think about is communities, and primarily communities of color, that have disproportionately high numbers of overdoses, that have disproportionately been impacted by the war on drugs, and who have unique thoughts about our system of care that we in this echo chamber that is here today won't ever hear if we don't get out and listen to. And so we need to do that. We need to do better at that to improve our system of care. After today, I have a ton of hope that this group is a great group to help inform those decisions and make recommendations. And I'm super encouraged by the legislators that are here today that will help impact that. But yeah, those are my comments, and I thank everybody for your service.
Thank you, Brad. Appreciate your passion for this work as always. I believe we have Thea up next if she's back on. Thea, if you're trying to speak, you're on mute. That happens sometimes.
Oh, sorry, I had to take my kiddo for a late drop off. Oh, it says I'm not on mute.
We can hear you now.
Oh, okay. Sorry, I had to drop my kiddo at the late, delayed start. So didn't plan to leave the meeting. I am really encouraged that there's so many people who were chosen for this committee that have harm reduction experience, but I am wondering why there isn't more representation from harm reduction organizations. And there seemed to be, when I was reading the roster of committee members, a lot of criminal legal representation. And I just have concerns as a person with lived experience, and also a professional in the field, that the overemphasis on criminal legal systems may not get us to the space that we're looking to go in. And so I'm hoping that maybe you could speak to that, and maybe you have some reasoning there that I'm just not aware of.
Sure. Thank you, Thea. I will do it briefly. The makeup of the committee was set by the legislature, by the bill. But I will say the spirit behind it is an intent, was really more about moving from a criminal justice solution or focus in addressing substance use disorders to a healthcare lens or perspective, if you will. So I think there's pretty good recognition that that's the charge of the committee is how do we look at this issue as a healthcare issue, and what do we have to do to put things in place or interventions or programs in place to meet people where they are, and take that from a healthcare perspective. So I will stop with that. Yeah, there's a lot more there. We would have loved to have, well, let me say this. It is a pretty robust committee. It's a large committee. It's a pretty big committee. There are sectors and spectrums that are not here that I think you've heard others talk about. We need to reach out to this group or that group. We're hoping as committee members, you can help us with that. You can talk to those groups or those organizations and kind of bring that perspective in. And we will be taking some of that into consideration in the planning process as well. So yeah, I will stop with that and see if anybody has anything else to add. And thank you for being here, and thank you for being persistent on getting on, Thea. I know a lot of youngsters are a couple hours late today, and I'm still looking at a lot of snow out my window. So do we have other individuals who would like to provide public comment?
Jessica Blows has her hand raised.
Okay. Michelle, I'm not seeing any other hands raised.
Oh, sorry, Jessica Blows.
Everyone, this is Jessica Blows at Healthcare Authority. I put a couple comments into the chat, but I do think, I know withdrawal management has been a topic that's come up repeatedly on this conversation today. It might be something in the future for our state to consider ambulatory withdrawal management and more opportunities to either increase it or create ambulatory withdrawal management. And then again, for those of you who aren't familiar with that term. It's really withdrawal management services that are offered at an outpatient level of care. So, for not all conditions would an individual actually need to go to an inpatient setting in a controlled environment. It might be a way to help meet a gap that's needed. Thanks.
Thank you, Jessica. Okay. Well, I think we'll get a report card back from our legislative friends on how we did with our first public comment, but thank you guys for signing up, and I think we got you all in that wanted to.
It looks like, sorry, Brad Finegood would like to make one more comment.
Just real quick, I apologize.
Right, Brad.
I know I took a lot of time earlier. I would just implore this group to take a look at some of the work that's came out of Caleb's shop and the ADAI around the recent syringe exchange survey. If we're really wanting to understand people who are having trouble accessing systems of care and systems of care that people really need, I think that is the most up-to-date information that we'll get, and trying to think about what are recommendations that should come out of what is currently going on for people. I think that would be a great thing for this group to hear and listen to.
Brad, actually, I just received that information last week, and I'm reviewing it now. So thank you for bringing it up. That's a really good survey that came out. Thank you.
Okay, anybody else? All right, this has been our first, we went from 1 hour to 2 hours. Now, we're not going to go to 3 hours in February, but we'll try to keep these at 2 hours and really, again, have some leading questions to draw out your perspectives. Hopefully you got the materials in time, ahead of time. I want to thank Michelle for doing that. And that this was a good meeting for you, that you were able to hear the conversation and participate when you wanted to. I'm going to, Senator Dingra, I always look at you as the sponsor here as we close out these meetings. And I think I will offer, I may not do this every time, given time will be half time today. So did you have any closing comments that you would want to make today for this group in our sort of first full meeting, if you will?
Yes, thank you so much. And I literally just hit send in the comments. I do want to thank everyone for participating and for sharing your thoughts. This is not an easy topic, as we have discussed and heard. There's a lot of personal stories, a lot of heartache that I think everyone on this call has experienced either personally or with family members or someone they know, or friends or neighbors. And I think it's just really important to make sure what we're putting front and center is saving lives, and making sure that we can get to policies, as Senator Braun said in the beginning, that provides access and resources. I think we have to meet people where they are at, and at the end of the day, we got to make sure that people stay alive. So thank you all so much for your hard work. I know it's going to continue to get harder, but we can only find solutions when we're all engaged.
Thank you, Senator. I concur with some comments earlier. It is quite impressive that we have all of you here, legislative members here, a week before session beginning, but it does show the, I think, the visibility to this issue and certainly the commitment to this issue. So thank you all for your leadership. Michelle, I'm going to turn it over to you for next steps and closing us out.
Sure. So the next steps, I'll be working with our note takers to compile the notes so everyone can see that. We'll have the meeting recording for you as usual in the summary email. And then also a heads up on the topic for the next meeting and what to expect in terms of that discussion. And then later in the month, I'll be sending out the agenda for the next meeting so everyone can have a heads up about that. And of course, in the meantime, if you ever have any questions or want to provide feedback about the ground rules or anything else, you can always email me with that feedback. So I believe that's all for wrap up and next steps for now.
Thank you, Michelle. Thank you, everybody. Happy 2022. And we look forward to this next month. So take care.